So make sure you do that PowerPoint. You look at it, it's got all your key concepts there. You know, week 7, we're getting close to the end now. So make sure you bone up on that. Now, if there's things you don't understand, of course, reach out to me and I can always do a one-to-one on you for you to understand it. But I think I do pretty good. And by past history, students have told me I've covered it well. So let's go ahead. Let's get to our Kahoots. This week, you have a discussion question due by tonight. And then you also have the ALL that you can do. So those are your 2 things that are due. Remember, next week is your pediatric assessment. It is a little bit of work, so I would start on it this week. If you can, I would like to, you know, when you pick your diagnosis, let me know what it is to make sure I don't get all of one thing. I like to be entertained and I like to be taught by you about different diagnoses. Remember, it could be something you had, your kid had, your next door neighbor, your best friend, your uncle, something that you want to learn more about. Make it more fun and more interesting for you. And that really does help. Remember, it's a virtual patient. Tell me what that patient looks like with that diagnosis, okay? All right, let's get going. Week 7, cerebral and endocrine. Crazy things to put together. Growth hormone is administered by what route? Now, the growth hormone is secreted by the pituitary gland, and it could be not enough or it could be too much. And both of those things either going to be a dwarf or gigantism. It's either or. So growth hormone tries to get the child to be as tall as they possibly could be. They stop it when they stop growing less than 1 inch a year, and that's when they just stop it. Now, it is a subcutaneous injection. It's like giving yourself insulin every morning, right? And it goes on. Sometimes it's weekly, daily. It all depends on the physician and what sort of growth hormone he wants to give. So growth hormone is an injection. So it has to be, to get that amount of the child and that parent doing it consistently, you really need to know that they're committed because it's an injection. And you know how kids feel about injections. Highest priority for a diagnosed patient with syndrome of inappropriate antidiuretic hormone. Well, look at what the name is. Antidiuretic. That means against urinating. That's as simple as it means. And thinking of that, they're getting too much hormone by the pituitary gland. It's the posterior lobe. The opposite is diabetes insipidus, when you're urinating too much, okay? So you have SIADH, which is you're just hanging on to your urine. And then diabetes insipidus has nothing to do with blood sugars, is when you urinate too much. So we're going to go into both of those. Which of the following are signs and symptoms of an inappropriate antidiuretic hormone? Again, antidiuretic. The words make it clear, against urinating. That makes it simple, doesn't it? So yeah, you're going to see decreased urinary output. As simple as that. What would you see? Weight gain. So what are we going to do for this child? Intake, output, and we're going to do daily weights, right? These are things we do besides other type of treatments. What is important to cover when teaching the family about polydipsia? It's also called PTU. It is used for hyperthyroidism. And one of the side effects is something that's common. And when we use it, we need to teach our family about it. because if a child's at home, sore throat, fever, it could be a normal viral disease, right? But it could be a side effect from the polyphyphate cell. So something we call the doctor about. A multi. An initial sign of diabetes insipidus. Again, opposite of syndrome of inappropriate antidiuretic hormone. Now we know what one of them is, but what is the other one? This is 2 Ps. You're urinating a lot and you're drinking a lot. What's very interesting about this, if an infant is born with diabetes insipidus, they'll drink and cry for a bottle, milk, 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 milk. Give them a bottle of water and they stop crying, they're satisfied. And that almost always will say, okay, we know it's diabetes insipidus without even looking at the pituitary gland and those hormones. And that's the posterior lobe of the pituitary gland. On multi, what are the clinical manifestations of juvenile hypothyroidism? Well, adults and children have the same thing except one. Remember, children are still growing. That's the difference. But all the signs and symptoms of thyroid is the same, adult children. They're going to have that dry skin, thinning hair, constipated, weight gain, usually, cold intolerance, all of that stuff. Same thing, but it's that decreased growth because you need thyroid hormone to grow properly. And remember, thyroid hormone is good for cognition. If they don't get it from birth, which many of them are born, of course, with hypothyroidism, they'll have cognitive delays. They need the thyroid hormone. Very important. A child is a simple febrile seizure. What education will you provide the parents? Febrile seizures are usually like 6 months to 6 years old. They grow out of them, thank goodness. My first grandson had only one febrile seizure. That mother had a thermometer and that kid 4 to 6 times a day. It was like ridiculous, but the kid never had another seizure. Now, the whole thing about febrile seizures, you could take temperatures all the time, but it's like in 20 minutes, they go from normal to a big fever. It's hard to catch a lot of the times. Well, when that fever goes, that rate of rise, they call it, really high, the brain just goes and sparks. It goes, I don't know what's going on here. And that's what causes the seizure. In any child having a seizure, no matter what, safety is number one, because we can't really do anything. We really cannot. So what are safety precautions? Turn them on the side in case they vomit, right? We don't want to have any aspiration. We're going to remove any sharp objects around them. We're going to have that bed flat. And we are going to call somebody else to help because it could go into status. And status means that they're going to need probably Ativan, benzodiazepine to help stop it, and maybe also giving another bolus of some sort of anti-seizure medicine. They love to give phenytoin is one of the ones I like to do during that time. What type of seizure is when the body's jerking, you're foaming at the mouth, and the child is rendered unconscious? And they usually are postictal when they're done. You know, they've changed the names on it since I've studied it. They used to call them grand mal when they got to this point, but it's tonic-clonic. That means they're up and down and they're moving. Again, safety is all we do. Call for help. What notable sign may indicate increased intracranial pressure in an infant? Remember, infants can't tell you their head hurts. They can't tell you they have blurred vision. They can't tell, they're not walking and falling over. There's nothing they can do to tell you. But their cry is horrible. It is like nails on a chalkboard. You go into a room of 20 babies and they're all crying, and there's one kid who has increased intracranial pressure or has a neurological something, that pitch of that cry is completely different. They're also inconsolable. They used to have to put them on me because I'm soft and cushiony and I'm very peaceful and I could put these kids to sleep, but they were very difficult to do that. Now, bulging fontanelle, yes, but at sleep, at rest. Crying, many infants have a bulging fontanelle. Doesn't mean anything. That's when they're at rest, okay? That's why that answer wasn't right. All of the following increased cranial pressure except what? You know, as nurses, especially if you have a child who has a head injury, we need to know what can make it worse and what do we have to be careful for. Excuse me. Now, heart rate has nothing to do with intracranial pressure, okay? So tachycardia doesn't do anything. But when you're touching a patient, if they're coughing, suctioning the patient, all of that will increase intracranial pressure. What findings can alert you to a head injury getting worse? You know, one of the things we do know with head injuries, you know, I've had many children come in with sports injuries. They slid into third base and their head hit the knee of the defender, and they come in and they're like, was I safe? Was I safe? Did we win the game? It starts with this amnesia sort of stuff. So change in orientation is the things. If there are that point and they're talking, asking questions, and they're sort of related, okay, you're good. But what if all of us say, where am I? What's going on? Now you're getting worse. And then it could be getting to the point where they're getting stuporous, and all of those things can happen. In head injuries, you're going to see headaches, and in children, you're going to see nausea and vomiting. And if it's getting worse, okay, even waking a child up out of sleep with a headache, then you know that head injury is progressing. Another multi. What does it mean when you see a fixed and dilated pupil after a head injury? A, that means one of them is like that. So if you have a child, adult, patient, doesn't matter, you have one fixed and dilated pupil, you know that that child is a neurological injury, and which means there's swelling going on that head. So if it continues, you're going to have a child who's probably in a brainstem injury, and that brainstem, you know, controls everything. Any patient who has any injury to that brainstem are never coming back. They're going to be, you know, maybe they're going to breathe, and that's, you know, and have their heart's going to beat, but they're not going to be with us. So we see that it's neurological emergency, treat it now, call the neurosurgeon, get this child to the OR. Give me 1 second. I have somebody outside who's stuck and can't get in. Sorry about that. Which of the following signs and symptoms are more common in children than adults following a head injury? I was just talking about this. Signs and symptoms, what to look for. You know, a kid can come in and they're just a little confused. But it's that nausea and vomiting, right? A kid will have nausea and vomiting. Adults rarely do. Mostly they'll complain of headaches, but they don't get into the nausea and the vomiting. Children do. That's the difference. What medication may be used for a child with cerebral edema due to a fall? Okay, swelling's going on in the brain. It's pushing on all of the vital parts, right? And it can push upon that pituitary gland. What's in that pituitary gland? What could happen? So you've got this head injury going on in there. It's squirting and it's trying to push on everything. There are two types of diuretics. You know, ones that we use for congestive failure, peripheral edema, that's furosemide. You have a child, an adult with massive swelling in the brain. Specific for the brain, the diuretic is mannitol. Mannitol can be used for acute renal failure sometimes and some toxic congestions, but most of all, this is used for swelling of the brain to get rid of that fluid quickly. That's why we watch intake and output on head injuries so closely. We don't want to overhydrate ever. Reye syndrome. Do you know what that is? It's because of aspirin. And there's some metabolic disorder that we don't know about before they take the aspirin, and it's in children. That's why any parent who says, well, I'll give the child aspirin if he has a fever, you're going, no. You're not going to give anything to that child except acetaminophen, and after 6 months old, you can add ibuprofen. No aspirin unless what? Kawasaki disease. It's the only time. Febrile seizures usually occur in what? So they usually begin about 6 months old and they'll go up to about 6 years old. I mean, I'm lucky my grandson never had another one and he's 11, so we're out of that ballpark. So thank goodness. Childhood hypopituitarism results in which condition? This is about that growth hormone, right? Pituitary does growth and it has urine regulation also. So it's going to be that pituitary dwarfism because it has to do with decreased secretion of the pituitary gland of the growth hormone. How would you describe precocious puberty? Now, this is boys and girls. You know, we think of puberty, we think mostly of girls and getting the menses, right? But it's early. It could be at 6 years old. And boys, you'll see them growing beards. And in girls, you'll start seeing their breast buds coming up. And can you imagine the amount of teasing that those children would have? So what they do is they give medicine to stop them from having puberty until it should be starting, which we know is 10 in girls and 12 in boys, right? We learned that earlier. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? Your thyroid don't work. What are you going to monitor? T3, T4, TSH. Growth hormones is pituitary. Cortisol is your adrenal glands, which has to do with steroids and aldosterone and cortisol, okay? And we're going to do a question on that too. How can you monitor a child with hypo or hyperthyroidism? Like, how would you even know that maybe something's going on? Think about it. What do we do every visit when we see a child? Then I'll ask you a question. When you go to the doctor's office, do they always, every time, do your height and weight? No. Kids, absolutely. Okay. I mean, maybe your doctor does, but mine doesn't. So maybe he should have. I don't know. What acid-base alteration would you see in a diabetic child with Kussmaul's respirations? Well, if they're in Kussmaul respirations, they are in diabetic ketoacidosis. So metabolically, they're acidotic. So the lungs are trying to work opposite of that. So it has to be respiratory, fighting the opposite to balance the acid. Now that's going to be alkalosis, okay? So when you have a condition that's acidotic, your lungs want to go alkalotic to try to get it in the middle. Just like opposite way around, if it's alkalotic, your lungs are going to go acidotic. So breathing fast or breathing slow and pursing and long respirations, okay? That's that acid-base problem. HESI has 4 acid-based questions, okay? So you're going to see some of these questions in the next couple of weeks in the HESIs, in the Cahoots. What would a child with Cushing syndrome look like? Cushing syndrome, adrenal. It's due to too much steroids. Usually the doctor prescribes them for a condition, gives too much, too long. And it even happens in children, and you gain weight on it. You know, I think I gained 40 pounds on it. I look like the Pillsbury Doughgirl. I mean, a big, just round. It was pretty horrible. Now, your arms and your legs are skinny, but then these children are going to have hair on their chins and on their upper lips that they don't normally have. They're going to have these big red cheeks. And of course, as I said, gaining weight. Remember, whenever we give steroids and we give high doses, we need to taper them off slowly, or you're going to run into an adrenal crisis. And the adrenal glands are kicking in, and then you're not going to feel well because you go hypertensive and you get chest pain and you get dizzy. So steroids must be tapered off. A multi again. You walk into a child's room, fever's 104.6, and you see them having a seizure. What can you do? What are you supposed to do for a child with a seizure? So you're going to turn them to the side, check the bed, side rails up, pat them, and you put the bed flat. So they're just there. And of course, if there is a call rescue team, absolutely, you always want extra help. Whether you need it in the end or not, better to be safe than sorry. Autoimmune disease of the thyroid gland. This usually happens in girls in late childhood, early adolescence. My daughter-in-law has this disease. It's something that you cannot remove the thyroid gland. You have to live with it. And you must monitor your thyroid levels regularly. And you must be taking thyroid supplements. There's usually 2 that they end up taking. And it's called Hashimoto for the person who found the disease. So that's autoimmune of the thyroid. Addison's disease. We have Cushing's and Addison's. These are both adrenals. So if Cushing is too much steroids or cortisol, their words are sort of synonymous. What is Addison's? It's a decrease of cortisol, but also aldosterone's there as part of the adrenal glands and what they do. Now, children usually born with Addison's disease and less that they need of these hormones, many of the time we don't know what gender they are at birth. There, you have to do a gender reassignment. They might have a vagina and they might have testicles. They might have a penis and they might have, the vagina. I mean, there's all different combinations. So they'll be on cortisol and aldosterone for life because this is the adrenal didn't secrete enough during pregnancy. And of course, they will for life. So they're going to need it. Another multi, a ventricular peritoneal shunt. So you have a kid who has a problem with their central nervous system and spinal fluid flowing up in the head and flowing down the spinal tract. And it doesn't drain. So the head keeps getting bigger and headaches and vomiting, and it's horrible. So instead of just doing periodic drainings of it, what they do is they put in what we call a VP shunt. We use it for that hydrocephalus or too much fluid on the head. And it's the thing that goes in, a little tube, goes into the fourth ventricle, comes behind the ear, and you'll feel like a little lump. It looks like you can pump it. Only the neurosurgeon can pump it. And then it goes down in the front of the chest, down into the peritoneum where it drains. So what do we as nursings do? Well, number one, we're going to be measuring that head circumference and abdominal girth at once a shift, minimum. We do not touch that pump. We leave it alone, okay? And that's all we do for a VP shunt. These children are taught as they grow older, of course, the shunts get too short and they disconnect. If they start having severe headaches and vomiting, they need to get into the ER because they probably need some sort of shunt revision. A common side of Graves' disease includes blank or protrusion of the eyes. Again, this is hyperthyroidism. It is called exophthalmos, protrusion of the eyes. There's a good commercial now on TV about that. Another multi. Hypoparathyroidism has the syndromes of tetanic muscle contractions and blank. Okay, when you're talking about the parathyroid, it has nothing to do with the thyroid. When you're talking about muscles, you're always going to think of two things, calcium and magnesium. They both control muscle, okay? This has to do with calcium, okay? Tetanic muscle is when you don't have enough. You can't move it. It's just limp, okay? And if it's too much, it's absolutely opposite. You see the paresthesia, et cetera, et cetera. So how do we monitor the parathyroid? Well, we monitor calcium levels. How do we treat it? We give calcium if that's what we need, okay? If it's too high, many a times they'll do surgery and get rid of it. Multi-select. What are the signs of hyperparathyroidism? It means too much. Calcium's in there. It's like the muscles go, hey, what's going on here? You're giving me too much of a good thing. So you do see nausea and vomiting. You get confused, but it's that paresthesia of the extremities because you're just they're an overload, okay? So those are the differences of the both. Just remember, parathyroid has everything to do with calcium. So what does the parathyroid hormone do? I put several questions on this because there was a concept in the HESI, and many students got it wrong. So I made sure that you know what it's all about now. So that's why that was there like that. Which of the following might be a cause of an adrenal crisis? I said it earlier. What does the adrenal gland do? Right? See, adrenal gland is all about cortisol. It's all about aldosterone. If you come off those, steroids too quickly, you'll go into an Addisonian crisis or adrenal crisis because the adrenal gland doesn't know what to do. So you put it into shock, basically. So how do you treat it? Well, you give some steroids, feed the body what it's trying to replace, and then slowly taper off the meds. A multi-select. The cardinal sign of diabetes insipidus. I'm repeating you here. Now, many people want to put polyphagia. That is diabetes, like mellitus. That is not insipidus. Diabetes insipidus, just like the name is spelled, only 2 P's. Now you're going to remember that. Polydipsia, polyuria, only 2 P's. Okay. I'm teaching you all my tricks, guys. A multi.
Is she frozen?
I think so. Yeah.
Yeah.
I don't know if we should take that as a sign or not.
You guys not connecting to?
Yeah, she's not even on here anymore. She's like completely.
Yeah, and my game keeps saying connect, reconnect.
Yeah.
But how is it still
Okay, I thought
recording?
it's just me.
Kayla, it was your fault you broke it.
No. Hey, we just got the
There we
objective
go.
for the Jacobs.
There we go.
I didn't even answer it.
Mine logged me completely out.
It just said I got it wrong.
I'm all the way out too.
Mine did too. Can somebody tell me what the PIN number was again?
I'm still
Hold
logged
on.
in.
Oh.
What's going on?
5531699. Can you hear me?
Yes, thank you.
That was like, what just happened?
Oh no, I'm gonna all over.
I'm at my daughter's house, so it's that Miami internet. I have to go back to my homestead next. What causes type 1 diabetes? I like this little picture up there. Bob had 36 candy bars. He ate 29. What does he have now? Diabetes. Really, that's not what it is, but I thought it was cute. So diabetes is when the pancreas, it's just usually autoimmune. It attacks the pancreas and it attacks those cells, and now it can't secrete insulin to digest the carbohydrates. So now your body says, I'm hungry, right? So what statement about a Theochromocytoma is correct? Now, this is an adrenal tumor. Part of what adrenal gland does is that cortisol, aldosterone. Remember I talked to you earlier about this adrenal crisis? You have this horrible feeling of hypertension and headaches and chest pain because it's a catecholamine type producing a tumor. And catecholamines is everything's up. That's sympathetic, that's fight or flight, that's up, up, up. And that's hypertension, tachycardia, and that chest pain and dizzy and feeling really awful. That's what a pheochromocytoma is. Now, they're hard to find, but once we find them, usually they go for surgery. So nursing care would be taking care of this. We need to monitor. If a patient said, I don't feel too good, you need to monitor the vital signs, right? Because it's a catecholamine that's being secreted. Well, what does a catecholamine affect? And that's what you're going to do. So what action should the nurse implement in the care of a patient with a pheochromocytoma? Again, blood pressure, heart rate has nothing to do with the glucose, and it has nothing to do with weight gain. Okay, this is all about a tumor secreting a catecholamine. It's like getting an injection of epinephrine. Simulate to that. It's like everything up, 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 up. Adrenaline. A multi-select. Nursing care, the unconscious child should include. You know, many times you get kids, maybe it's a head injury. Many a times we're going to intubate them, paralyze, sedate them. They're going to be on bed rest long time. And we need to take care of them because they can't do. Now, always unconscious, think head injury. Always monitor your intake and output. We don't want fluid overload. Always you monitor your neurosigns to see if there's any changes. And of course, you're going to do the vital signs and also check the temperature as needed. Pain control depends, but usually they'll be on a little bit of sedation to keep them calm because usually there's a reason why. Symptoms of DKA. Diabetic ketoacidosis is when the pancreas can't secrete enough insulin. So the body needs to find food because they're hungry. And they say, all right, let me start eating proteins and let me start eating fats.
Professor Bogart.
Ketones. And those ketones have it go rotten in a Tupperware container in the refrigerator and then open it up 3-4 weeks later. You're going to smell a rotten, sweet something. It's not disgusting, but it's really sweet. That's what that breath smells like. Ketonuria, and of course, you're going to have high blood sugars. And your pH is going to be low. A multi. So in adolescents with a BMI above 95%, is urinating a lot. What test can you anticipate? Now, BMI of 95% is basically called obese, right? And they're urinating. So we always will do a urinalysis to rule that out for sure. They're urinating a lot, so we're worried about potassium, so electrolytes. And then that hemoglobin A1C is going to talk all about the sugars for the last 3 or 4 months, where they are to see if it is diabetes. Very good, guys. Pregnancy tests? Not really. They might, though. Diabetic ketoacidosis is caused by what? Well, what causes those ketone bodies to start? We know diabetes is when your body can't absorb sugar. So the body says they're hungry. So they said, okay, sugar, you're not feeding me. Let's go find my fats and proteins, right? And it starts eating them up and ketones are made. And that's why you see all those symptoms that go along with it. I've seen these kids come in with 1,101, I think was the highest I've seen, of blood sugar. This child's pH was 6.9. Came in lethargic and pale, sweaty. And we got that blood sugar down. The kid, by the time we sent him up to the ICU, was pink, awake, and alert. It's amazing the change that you see in these children. Quick. Another multi. So a child's emitted of blood sugar greater than 600 and large ketones in the urine. What do you do first? Priority intervention. Number one, you want to dilute that blood sugar. So you give a bolus of saline. Now, as you're doing that, another nurse is preparing you, or you're sent to the pharmacy for an insulin drip, which will be a slow, continuous drip of insulin, of regular insulin. We don't give anything sub-Q. We need to monitor that blood sugar and be in control of it. Sub-Q or not. Now, electrolytes, that's down the line. Because when they come in, you start the IV, you draw all the bloods, which is, of course, going to be a whole panel of electrolytes, etc. Once we get that potassium, then we'll be concerned about it. But IV bolus and start that insulin drip. Number one is the bolus. So a diabetic child's complaining, feeling jittery. Blood sugar is 45. What's the best treatment? The key word in this whole question is the child is complaining. Because we know if they were unconscious, it would be a different treatment, right? It might be a D50 bolus amp, some of that, or it could be glucagon. But in a kid, give them a glass of milk, give them a glass of orange juice. Both of those work really well. Get that blood sugar up. Give them more insulin, I think we'll probably kill the kid with more insulin. No. Your patient has experienced a head injury. What would most concern you? You got to think about this one. Head injury, swelling going on in the brain. Sort of mentioned it earlier. Pushing against maybe the pituitary gland, and maybe we have some secretions of antidiuretic hormone or something going on. That decreasing urinary output is a clue. We need to do something now. That's telling you something's happening. We need to get something quick. Another multi. How do you detect ketoacidosis? So ketoacidosis is diabetic ketoacidosis. Sugars are off the wall. It's in the urine. It's in the blood. And of course, your ketones are also going to be there. Dehydration, it may or may not, but the other ones, absolutely. A multi. What would alert you that a head injury is deteriorating? So again, it has to do with the level of alert. Now the kid is getting restless. Something is more going on there. I mean, if you had a headache that was getting worse or the vomiting's getting worse, which is like a brain tumor, if we remember last week about it, but those two, absolutely, something's going on. And we know it's probably increased pressure and maybe needs surgery. So you have a child diagnosed with bacterial meningitis. What is the nursing priority of care? So you just get an infant up to your floor or a child, it's bacterial meningitis. What is your priority? Your antibiotics are number one. Very good. Good job. What is a primary cause of injury associated with submersion? You know, I live in South Florida and I've seen many a drowning, and they're not nice. A lot of these kids drown, they come up, they're running around the pool by the time rescue comes, and they don't want to go to the hospital. Problem is, you can have acute respiratory distress syndrome within 72 hours after submersion. And it's because they've inhaled all this water, they're not getting oxygenated. Therefore, the answer is hypoxemia or hypoxia. Okay, that's why it's that. It's not pneumonia, not increased pressure. It's not hyperthermia. Okay, well, maybe it was hypo, but it's a lack of oxygen. And then the lungs get upset and they can die after 72 hours. They go into this ARDS. So a multi. You have your cerebral spinal fluid came back. The results correlate with bacterial meningitis DOTA. So which one of these things would you see? If you have a viral spinal tap, viral meningitis, it's going to be clear. It's crystal clear. If it's bacterial, it's going to look white and milky because you have an elevated white counts in there. Sometimes they're too numerous to count. I mean, it almost looks like milk sometimes. Bacteria loves glucose, sugar, so it eats it. And then, of course, it leaves the protein alone and they're elevated. So there we go for today. Number 3, Mayona. Good job, Mayona. These were some rough ones. Brittany, good job, Brittany. Number 1, Gianna. Good job, Gianna. And Y and Kristen, good job. All right. So remember, you have your discussion question. Make sure that you do your case study. They're still open to do the last week 2 case studies and the set of NCLEX till Sunday if you didn't get it done. Remember, that's about 3% of your grade. So if you haven't, make sure you do get it done, okay? It will be minus 10%, but it's better than nothing if you haven't. So anyway, thank you guys. Been a great class as always. I'll see you next
Professor
week.
Bogart, I
Thank
want
you.
to for a second before class.
Sure.
Like a private